live. I am so excited to have you with us today. So please, if you're here live in the comments, let us know where you're tuning in from, what city, what state, and what country if you're outside the US. And I want to tell you, today we are going to talk about how having complete medical records improve care and outcomes. And we have the fantastic Linda Van Horn with us. And I just adore Linda. I first met her through Startup Health. Both of our companies are in the Startup Health portfolio. And what I love about her is she's invented sort of this translator for electronic health records, EHRs. I'm going to let her tell you a little bit more about it. Linda has a whole bunch of initials after her name, so she's totally qualified. I'm really happy to introduce her. She is the founder and CEO, I believe, of iShare Medical. Linda, thank you so much for coming on live today.
Great. Well, thank you for that wonderful introduction. And I'm really excited about this topic because I feel that a lot of times physicians and patients don't get complete information. And it's so important to your care and outcomes having a complete information. So it's great to be here. Thank you.
Well, I am thrilled to have you. So I would love for you to talk to us about the history of medical records.
Yeah, absolutely. So, in the beginning, there was a personal relationship, and there still is. I don't mean to say that it really doesn't exist, but there was a personal relationship. People went to their local doctor. Everybody knew everybody else's families. And when you needed care, your doctor pretty much knew everything about you. In fact, in the early days of hospitals, all the doctors charted into the same medical record. It was typically kept on the end of the bed, and they would go walk in the room, pull the chart, start going through it, scribbling things in it about seeing it. So there was this complete medical record, and there was a lot of care coordination because if another caregiver, a nurse or a doctor or someone else came in the room, they could just grab that chart and see it. Yeah. But over time, medical records became very fragmented and siloed. And so each provider created their own record of the patient's care. And so every time you would go to the doctor, a new doctor, it would be like 50 first dates because they really didn't get the records. Right. They had to ask you all these questions over and over again. And still today, it's kind of 50 first dates because they want to go through your medical records and make sure that they have right information. And right now, still today in our system, we rely on the patient to be their own health historian. And patients are really good people. They don't mean to leave stuff out, but right. They have to remember all this stuff, and they're not very good health historians in many cases. So they forget key information that really can make a difference in their care and outcome.
Yeah, I want to share two stories that I think really illustrate your point. The first about paper records. So when my sister Adrienne was first hospitalized for her stage 4 cancer and going through chemo, Children's Hospital Los Angeles was making that transition from paper records to digital records. This was 20 years ago. The second time she came in for chemo, they tell us that they lost her medical record during that transition. Now, it had been like 3 weeks before, and they had lost it. And the doctors and nurses didn't like that I wrote everything down. So caregivers, shout out, write everything down. And so I kept this medical diary, if you will. And so they actually had to come to me and ask how much Dilaudid they had given her during the first round of chemo when she was going through pain, because they didn't know, because the paper record was gone, totally gone. I don't know if they ever recovered it. So there's that. But then on the flip side to what you're talking about, the fragmentation, I get so frustrated now as a patient when, I go to a doctor, let's say a specialist, and he doesn't have any results of any records whatsoever, even though it's the same insurance, Blue Cross Blue Shield of Alabama. They're all in network, and they're in the same building, often just a floor apart from each other. And yet the test that I had with this one doctor, the other doctor can't see because they use different EHRs. How did that happen?
Right. Well, um, gosh, that is a big question. First of all, let me say that I'm sorry about the care that your sister received, and I'm
Thank you.
grateful that you did write everything down. And I do think that's a lesson for all of any caregivers that are on the call, and even any providers that are on the call. It's really important for the patients to be engaged, and to have someone, if they're not able to take that recording down or whatever, but be an active participant in your care, because it really helps, because you'll remember things perhaps that your providers don't know. And I'll give you a real quick example about that, but I do want to also be sure and get to the fragmented, redundant, and not interoperability is what we call it in healthcare problem that you discussed. But the let's say there's a patient and they know they're allergic to shellfish, but they think, oh, that's a food allergy. I eat shrimp and I get sick. I have an allergic reaction. So they don't think anything about it. But then they go to have a diagnostic radiology test. And then it's part of the test, they're going to inject a dye to try to outline, let's say, a nerve or something like that, so they can pinpoint it and see it on the film. Well, the dye that we use, Omnipaque and IsoView, are iodine based. And if you have shellfish allergies, you'll typically have a reaction to that. So knowing that you have a shellfish reaction is really important. If the patient just dismisses it, yeah, I'm allergic to shellfish, that's no big deal, they may not realize the downstream implications of that. So that's why complete medical records are so important to help avoid making a preventable medical mistake. And so when your doctor asks you all these questions about stuff that seems irrelevant, sometimes it's very relevant, that information that they need to know. And to address the other question that Andrea lost, and I've lost Andrea on the feed, so hopefully, Andrea, you're still with us, or I'm still with you guys. I don't know which, but I'll go ahead and answer the question. The show will go on, I guess. So when you have a situation where you have multiple different caregivers, and that's pretty much a given, especially for people who have complex conditions. So if you have, multiple different diseases, maybe heart disease, diabetes, maybe you have cancer. There's a lot of things going on. You're going to see probably different specialists, because there is a specialist for diabetes, endocrinologist. There's a specialist maybe for your cardiologist for your heart disease. Maybe you have also oncologists. Maybe you have an oncological surgeon. It's very important to coordinate care across organizational boundaries. And so the example you gave, here's my doctors, they're all in the same building and they're still not communicating with each other. They may or may not have different EHRs. They could be on the same EHR. So this is the problem that the federal government, there's an agency in the federal government called the Office of National Coordinator for Health IT. And they have been working now for some time, a couple of days, and get us to be interoperable. So there's some really cool stuff that's happened, but interoperability is a very fancy term that just means sharing the information. And so we need to be able to, the people that are involved in the care of the patient themselves, and anyone the patient wants to have access to their information should have the ability to get their information so that they will know what's going on. Plus, like we talked about the shellfish situation, having that information could be a very big part of the patient's care. I'll use an example of how impactful this is. Johns Hopkins did a study. Dr. McCary was one of the leads on that. There was actually 2 physicians involved, but they did a study of preventable medical errors. And they found that the 3rd leading cause of death in the United States are preventable medical errors caused by poorly coordinated care. So it is so important that care is coordinated, and that information doesn't get missed. So having that complete medical record, which is our topic today and my passion of getting that done, But being able to get your complete medical record and with enough detail.
Yeah.
So many times today we exchange what's called a continuum of care document, which is great, but it's a summary. It does list your problems, your allergies, your medications, and things like that. But it it does not contain the medical decision making that the provider goes through when they're deciding that. And that's so important to understand. What is the doctor thinking? What is the plan? We do a lot of diagnostic testing to find out what is really the root cause of the problem. And once we can diagnose it, then we can begin to really effectively treat that, hopefully.
Wow. Gosh, I have so much to say. Um, so one of the things I love about what you do is that you sort of solve this problem, right? I mean, you help different EHR systems talk to each other. Would that be accurate?
Yes, absolutely. I like to think of an EHR as a cell phone.
Okay.
And so you can go out and you can buy a cell phone. And if you do, you get like an iPhone or an Android. You have a really great tool, but you can't make a phone call.
Mm.
And you can't make a phone call till you hook it up to AT&T, Verizon, or Sprint, or some other carrier. So we are what's called a HISP, a Health Information Services Provider, which is a big term to say we help the EHRs talk to each other. So we do bidirectional sharing. Not all EHRs will accept bidirectional. In other words, they'll let me get information, but they won't let me put information back into the EHR. But bidirectional sharing of data throughout the healthcare system.
I'm putting that in. So I'm going to put Linda on the spot here. I know you actually have a personal story behind this,
Oh,
why you're so passionate about it. Would you be open to sharing that?
sure, sure. One of my best friends, um, she had a rare genetic disorder, and we didn't really understand in the past, and we probably don't understand enough now either. But we learn everything. We learn all the time, and that's the great thing about the evolution. But she had a rare genetic disorder, and when she was a kid, she would have multiple childhood diseases over and over again. She had the mumps, she had the measles, she had a lot of autoimmune immune diseases like diabetes and rheumatoid arthritis. And the particular form of rheumatoid arthritis made it difficult for her to breathe because it attacks her lungs, which is a very rare side effect. And so every time she would go to the doctors, her doctors would say, this can't happen, or this is really rare. And she actually finally, one of her doctors said, I'm going to send you to the Mayo Clinic. And the Mayo Clinic looked at her complete medical records, evaluated her, and they found that she did have this rare genetic disease that was treatable with immunoglobulin injections or infusions. So she got infusions monthly in the beginning, and then they went more frequently. That ended up giving her years of healthy living.
Wow. And she could have had that all along if someone had just seen
Well,
the big
yes. I mean,
picture.
it's hard to second guess, right? I think that's hard to do because, we learn stuff like in the beginning. I'll use cancer as an example. In the beginning of studying cancer, we thought the most important thing was typing the cancer. What type of cancer is this? So we typed the tissue and we said, well, this is this kind of cancer. And then we developed drugs to treat that kind of cancer. And so what happened in clinical trials and in reality, we would give the same drug to the same people who had the same tumor. And some of them thrived and did really
Right.
well, and some of them didn't do so well. And they said, what is going on here? These people have the same tumor. And then they realized that genetics played a major role. And so today we look at not just the type of cancer, the tumor that the patient has, we also need to look at the patient's DNA to see if they will be a receptor for that drug. You see, a lot of medications that are prescribed to people today actually either do no good or do harm to the
Yeah.
patient. And it's based upon your DNA. It's all in your genes. how you react to medication. So I see this as, this is my future think. I think this is going to be one of the big revolutions of this decade, is being able to look at the medications and the patient's DNA and say, based upon there's really a quadrant, right? That there's four things: what it either works or doesn't work, and it's toxic or non-toxic. So we care about, if we're prescribing a medication to a patient and it works and it's not toxic, that's the goal, right? But there are sometimes we have to prescribe medications to a patient that work, but they're kind of toxic. Chemotherapy sometimes falls in that place, right? Yes, it's going to help the cancer, but we have to be very careful because it could hurt the host, right? The person. So, I think that's going to be the big revolution, is making sure that we get the right medications to the right patient for their DNA at the right time, so that we can help improve care and outcomes. And all that stuff is really fundamentally, believe it or not, based on the medical record. Because if your doctor knows your DNA, knows the medication, knows in case we were just talking about cancer, knows the cancer type, then they can say, okay, these things are going to work. And these things may work or are going to work, but they're going to be toxic. Or these things are toxic to you. They're not going to do you any good, and they're toxic. So let's just not do that. Right?
Right. Gosh, yeah. I hope we're going that direction. I know that you have this really great client story, because we did a little pre-interview prep. And so I was wondering if you could tell us that client story with, of course, not telling us who the client is,
Oh,
but it's
yeah.
a
I was like,
really
oh, what
funny.
is she? Oh, yeah. I remember
But
it
tell us
now.
that client story.
Okay. So before I founded iShare Medical, I worked in, I'm a serial entrepreneur. This is my third company, but my first company I founded was the Pain Institute. And so that's why I talk a lot about sometimes pain in my examples. But I sold my interest in the Pain Institute. We had 22 locations in 2 states, and I founded 21st Century Edge. And I worked as a consultant, working with hospitals and physicians throughout the United States on billing, coding, reimbursement, and medical records and things like that. And I was working with a hospital, and the hospital had, and I don't want to name the product, but the hospital had an EHR system. And they had, the EHR system was used both in their inpatient and their outpatient departments. Now, my doctor, we were looking to look at the departmental for their pain department. We were looking at the departmental numbers, and we wanted to understand the number of patients, the revenue generated, the costs, and things like that were associated with the different things that this doctor and department did. So we were looking at the numbers, inpatient and outpatient. And so we were trying to get this doctor's data from the inpatient side. And what was happened was, we were not able to share information in the same hospital with the same EHR from the inpatient to the outpatient. We couldn't get the data from the inpatient system on this doctor's numbers. And it's kind of blows your mind when you think that the same EHR can't talk to itself. So, we have a lot of opportunity for improvement in sharing medical records and being able to do that bidirectional sharing. And a lot of it's foundational. It's so easy to criticize and so hard to build. And I really try to focus on building, the solution. But you have to recognize the problem. If you don't realize that you have a problem, you can't fix it. So the first step is understanding what the problem is, and then you can look at the solutions for it.
So if your solution was implemented, let's say nationwide, would that stop patients from having to provide their information over and over and over when they go to the doctor? Because it's one thing to say, okay, yes, I need to do some updates, but now whenever I go to the doctor, and it's a doctor I've been to before, and yet they still, please list your surgeries, list your medications. I just give them a piece of paper and say, it's right there. It's in my records. There has been no change. I understand if there's been a change, totally get that. But I don't understand why I, as a patient, have to continually fill out papers every single time I go to the doctor.
You know, I don't understand that either, right? Because the medical records are there. Now, I will say that there is a good reason because information can be out of date. So if I look at I'll use an example of penicillin, right? We all know it typically some kind of penicillin or antibiotic is given for short duration. So if I look at a chart and it says this person is on an antibiotic, chances are they're not anymore, right? Because that's something that has ended. So having a provider say, "Are you still taking this antibiotic?" And the patient saying, well, "No, that was months ago. I am not taking that." That's appropriate, right? So it's
Right.
very important for doctors to be able and other caregivers to be able to ask questions about the medical record, especially if they aren't sure what it means. I'll give you an example. We typically put the abbreviation NKA in a chart, which means kind of no known allergies.
Mm.
But what if I opened up a chart and it said NA on allergies? Does that mean not applicable? Does that mean I don't know? So in that case, if I was a provider, I would probably say, you have any allergies?" Just to make sure, right?
Right.
Because the consequences of not knowing about an allergy. So I think that there'll always be some questioning that a provider is going to do. But I will say this, which is I believe that we as a health system have to trust our medical records. And the beginning of trusting our medical records is having complete information. So if I am a provider and I don't know if you've been somewhere else, so, so many times providers, well, I would say sometimes providers think they're the only provider who cares for you. And so they don't ask that and they don't know. So I'll use an example. Let's say that you're going to this primary, you've been going to them for years, and you get this weirdo mold. And your mom went to some dermatologist that looked at their weirdo mold. So you call up that dermatologist's office and you go and have it looked at. And lo and behold, it turns out that it's precancerous or it's God forbid, something like melanoma, which is a very serious type of skin cancer.
Right.
They take off the mold, they're treating you for it. Now you go back to your primary. Primary has no idea. See, people think that their doctors know everything about them, but that doctor probably has no idea that you've just been recently treated. And especially if that was a severe form of skin cancer, that they wouldn't know that. And that's important for them to know that. So they have to ask, where have you been since you last got here? Now, what should happen is we should trigger a message from that dermatologist and say, your patient was seen. So let me just talk a minute about a recent rule by CMS and a product that we developed for that rule, which is event notifications, iShare Medical event notifications. So what happens is when a patient is admitted, discharged, or transferred from a hospital, this new rule says if you have Medicare, your doctors, that is your primary care doctor, and anyone the patient says they're seeing as a doctor or subscribes to get information about you has to be notified. The hospital has to make a reasonable attempt to notify you. So what happens is beautiful because let's say you're a primary care doctor, you've got like 2,500 patients, and you say to the hospital that you typically go to, or a couple of hospitals that you go to, hey, here's a list of my 2,500 patients that I if anything happens to them, you let me know because I want to know what's going on. I want to take care of them. So now the hospital would send you a message. It's automagic. I like to say automagic, not automatic. So upon admission, boom, that message goes out to your doctor. Your patient has been admitted. Your patient has been discharged. Now, if I'm a doctor and I find out my patient got discharged, I'm going to do two things. I'm going to reconcile their medications because a lot of times medications get changed in the hospital. But the second thing I'm going to do is I'm going to get them in because to see me, to see what happened and talk to them, see how they're doing, make sure they're getting the right care. When patients see their primary care physician within 7 days of discharge, it dramatically decreases the fact that they'll be readmitted to the hospital. And this is so important. And I think the number, and I'm not sure of the number, I probably shouldn't say it because I don't know, but it was somewhere around $3 billion in savings to Medicare just
Wow.
by having the patient see their primary within 7 days. It's so important. Reconcile the medications, because let's say I'm the primary, assuming, and I'm not by the way, I'm not a physician, but assume I'm the primary and I'm seeing the patient and I'm prescribing high blood pressure medicine. They go into the hospital and somebody changes their high blood pressure medication. Well, I don't know that. So I continue prescribing. And the patient doesn't realize it's for the same thing. So they fill two scripts, the one they got from the hospital for blood pressure and the one that I've been giving them for years for blood pressure. And now they're getting too much blood pressure medication, which could cause their blood pressure to go too low. And they might pass out. Maybe they pass out and fall down, they break a hip or something like that. So it's so important to reconcile the medications, understand what changed. If I know my patient's been discharged, I can do that. And that's going to be in the best interest of the patient. And it's, and for their care, that the doctor knows what's going on. So I'm so excited about event notifications for this reason, because as I said, hospitals as of May 1st this year, hospitals have to send those notifications out. And as a patient, when you get admitted, if you're asked in admission by the hospital, who are the doctors that are taking care of you? If you want them to be informed about what's going on, be sure and say, I go to ABC doctors, these are my doctors, and then they will get these notifications, or should get these notifications. I can't tell you what people are going to carry through with, but hopefully they'll be put in the system and they'll be getting these notifications so they can improve. I will say, I recently spoke to a doctor and she was telling me a story about one of her patients that she had been caring for years. And the patient's daughter called her up and said, I can't believe that you didn't come and see my mother or check in on my mother when she was in the hospital. And the doctor said, I didn't know. I had no idea. And
Oh,
she was really crushed about this. She said, I felt so bad. She said, I didn't know. So now we can make sure, at least with Medicare. Now the other insurance companies, I hope, will follow suit. But at least with Medicare, that's required by Medicare that the patient's doctors get notified. I think it's so good for care. And that's part of that complete medical record. People probably thought, well, what does she have to talk about for so long about medical records? Right? But it's
so
about care coordination and getting the information to the right people.
so I have a question to ask you that I just thought of that we didn't prep for at all.
Sure.
So how do you feel about qualitative data in a medical record? I'm going to give you 3 examples. One that was positive, 2 are negative. When I saw in my sister's medical record that her physician, the one we liked, had called her delightful. For me, as her caregiver and as her guardian, it just made me feel good. It made me feel like that he saw her as a 15-year-old young woman and not just a pediatric cancer patient. But of course, that was not medically necessary, right? To put that was his impression of her as a young woman. That was not necessary to be in her medical record, but it was. But for 2 negative examples, I once saw, this was years ago, in my medical records from a hematologist, so not a MFT, not a psychologist, not a psychiatrist, but from a hematologist, may suffer from hysteria. And I was like, what? What? I don't think he knew I was going to read it. I was like, what are you talking about? So there's that. And then I've also heard very recently from some members of Cancer U, one in particular who was very upset in her medical record when it said she speaks and dresses well. And she took that personally and felt like it was racist because she's African American. So how do you feel about qualitative data like that in a medical record when it's clearly not medically necessary?
So there actually is a part of the medical record where that is valid, believe it or not.
Okay.
There's an area called constitutional. And
Okay.
what constitutional has to do with is overall impression of the patient. So you'll often see that people speak say in that the patient is obese, or a patient is at the right weight. You'll also see things like pleasant. So believe it or not, being speaks to your mood, and it is a psychological indicator. And if you're scoring a medical record, you would get, if you will, points. Medical records are scored, and then you get points on them for billing purposes if they're indicated complete or not. So, and some of those things are also about social determinants of health. So you might have been asked at some visit, do you feel safe at home? Do you have a home? I mean, social determinants of health are things like, do you have adequate food? So you'll see well-nourished, for example, will
Got
be
it.
in a medical record. And that's because the provider's trying to say this person has safe housing, they have food, um, and things like that, would be a determinant. If a person does not, especially a child, but probably any person, if you don't have adequate food in your home, or access to adequate food, it affects your ability to learn and so many other things. So that is actually a hot topic right now, is about social determinants of health. So you'll see medical providers becoming what some people feel are kind of intrusive, but they're
Okay.
trying to say, if I don't look at the whole thing, so you may come to me, I can treat you the best way possible. I can give you a prescription, but if you don't have the money to fill the prescription and take the medications,
Yeah, that's a good
then
point.
what good was that? So if I know that, there are sometimes pharmaceutical companies will offer um, discounts for people who cannot afford their medication that are truly indigent. They have to be careful. There's some rules about what they can and cannot do with regard to insurance, patients that have insurance. But if you're truly indigent, there's usually some safety net providers who can make sure that you get food and clothing and housing, and or help you in some way. So so what might seem kind of intrusive to say she's well dressed or well nourished, or has a pleasant, good appearance. It speaks to other things that they're trying to make sure that the patient, that they're looking beyond just the blood pressure, and looking at all the other factors that could affect a person's health. Because if you're homeless, it's pretty hard to get a good night's sleep. Probably, I don't know. I don't want to
Yeah.
ever know, right?
Let's see. Stuart agrees with you. He says qualitative data could be helpful for dementia patients. Very good point. And Janine says some of that is subjective and can vary by provider interpretation, though. And I totally agree. And
Yeah.
actually, what I do that makes people laugh, even my doctors, is that little section. Again, they make me fill this out every time, that says single, married, widowed, or divorced. I cross out all 4 boxes and I just write happy in all capital letters because they know my status. They have an advance directive for me. They know everything about me. So I just cross it out, say happy. So you don't need to know that other stuff. Okay, Linda. So what do you think the future of medical records is going to look like? What's the future?
Yeah, I love this question because this is something I speak about a lot. I do a monthly webinar series, and we do post all the webinars on our website, which is isharemedical.com. But I love to think about the future, and because if you can dream about the future, you can create it. And so I really believe we are on the beginning right now, is the beginning of radical interoperability. We have a couple things that went to do that, but one of them is the anti-blocking rule, which says that a provider cannot, the provider has to give you access to your medical records, and they have to give other doctors access to your medical records. In the past, providers could not share your medical records with another provider that asked for them. It's
I don't think I
unbelievable.
knew that. Wow.
There's now a federal law. The federal government studied this, and they said people weren't sharing medical records for anti-competitive behavior. And now they're mandated. So they're required by law. So know that you can get your medical records. There are a few exceptions. If the doctor thinks it's going to cause you harm, they can withhold that. But in general, you get access to all your medical records. So that's really phenomenal. And that just happened this year, believe it or not. So the future of medical records, I think once you have all this data, we will be able to use modern tools like artificial intelligence, machine learning, something known as deep learning or trained neural networks, that will bring correlations to the data that we never realized existed. So these kind of tools, especially trained neural networks, which is the most complex part of the tools that they can look at a million different factors against another million different factors and say, hey, these patients that all have this condition all had this other thing, and start to look at, okay, now that we know that data, what can we do? And the whole thing is about being able to detect, prevent, and treat diseases sooner. So I really believe the cornerstone of all of this is the medical record or the data, right?
Yeah.
And if we can analyze that data, and I know some people get concerned about, in the end, there's always a doctor or a provider who's going to be making those decisions. I do not believe right now that these tools are sophisticated enough, and maybe they never will be, to replace the human mind, because the human mind's so amazingly complex. And I'll use an example. If you were to do a trained neural network and feed it historical data about the United States, it would say it was impossible for a woman to be elected president of the United States because we've never had one. And that's what's called built-in biases to models. So you have to really look at what you're doing. And that's just kind of a crazy example, but it's true. We've never had a woman president. So a computer would say, there's never been one. It's not possible to have one. So that's where you have to take out biases in the models. So I do think there's limitations. But another example of that is like radiology, where radiology is, you're comparing two films. And what you're doing with the human eye, a radiologist who's incredibly trained to do this, is trying to find a difference. Well, computer programs can do pattern recognition and find it. If you ever looked at one of those books when you were a kid, see what's different between these two pictures, what's the thing that's been added? Oh, there's a pair of shoes in this one that's not in that one. You circle all the differences. I love to do this when I was a kid. That's what a computer can do super fast, right? Because it just looks at that and says, where's the difference? Looked at all those vectors and say, here's the difference. This is different. So that helps the radiologist to pinpoint what's going on maybe faster, because it's so small of a change. The computer might be able to see it faster than a human would be able to see it. So they're aids to providers. But anyway, in terms of the future, I think we have this very, very bright future of, now that we can start beginning to capture all this data, get complete information, analyze it, to look at not just what happened in the past, monitor in real time what's happening now, and predict which most likely happen, so that we can detect and prevent and treat diseases sooner. And that, I think, does improve care and outcomes for the future.
Let's see. We have a couple of comments and questions. So, define causes harm. That too can be subjective and doesn't allow the patient any informed consent and or decision making. So what are your
Such a good question.
That?
Such a good question. And an extreme example, I knew of a gentleman. He actually lectured at a ONC meeting, and he was a scientist. He studied cancer, and he knew a lot about it. And he got a brain tumor. And he tried really, really hard. He even lectured about it. He basically said, and I think it was like softball size. I mean, they took out a huge tumor out of his brain, and he pushed for access to his medical records. And he would lecture about it. He never got his medical records, and about how bad that was. Wow. And the problem was, he knew too much. His providers feared that would do him harm, so they didn't want to take away his hope. And to me, that's a provider, medical decision decision. I wouldn't even want to go near it, because I feel like patients do have a right to know. I'm a huge patient advocate. I think we worry that the patient's not going to understand it or whatever. Well, then explain it to them. Put it in language that they have. My aunt, who I adored, had cancer and passed away. And her doctor, the last time that she was in the doctor's office. He before she passed away, and she told me this story. He said, God has a room for you in heaven, and he's getting it ready. And that's the way he told her.
That she was dying. Oh, okay. We have a whole nother discussion about this. I would say one thing, and then we got more comments for you. I once had a total meltdown at a conference and had an argument, like standing, like face-to-face argument with this Egyptian doctor. And it was respectful, but it was just, I was livid with him because he treats a lot of liver cancer patients, and that's the area I know best. And he never tells his patients they're dying, ever, ever. And he told me, when I asked why, and I kept drilling deep, he said, because if I were dying, I wouldn't want to know. And I said, well, that's because you're treating your patients the way you want to be treated. And that's wrong. And everybody thinks that's the golden rule. Well, no, no, no. You need to treat your patients the way they want to be treated.
Right.
And I think I got to him a little bit because I just said, look, you need to just ask your patients how much they want to know and when do they want to know it. You just need to ask them, because there are people who don't want to know, but
Right.
maybe their caregivers do. But maybe they do want to know, but you need to gauge that as a physician. I mean, there's a science, but also there's an art to being a clinician, especially if you're in a disease space where a lot of people die from that disease. So, all right, off my soapbox. We have a couple more comments here.
Can I do a follow-up to that one, though? Because I think
go ahead.
Important. I think that it's important not to give people an expiration date.
Yes.
But I do think that it's important for people to know how serious their illness is.
Yep.
And so I'll use one more example, and these are true stories. This is really a friend of mine. A friend of mine had a genetic disorder, a birth defect when she was born. And this birth defect caused urine to back up into her kidneys, and she would get repeated kidney infections. And she ended up getting quite a bit of kidney damage as a result of it, because her parents didn't really know. She was a kid. They thought she was just a healthy kid. And they didn't really, recognize it until she had sustained quite a bit of damage. And she was told as a teenager she would probably never live to be 21. She ended up making decisions based upon those kinds of things. But she also did go to the Mayo Clinic. And I guess these are just true stories of two of my friends that went to the Mayo Clinic, are true. Went to the Mayo Clinic. They did an experimental surgery, which she refers to as they replumbed her kidneys. But they did, and they did put she was one of the first people that they ever did an artificial, not artificial. I'm sorry, it was a pig, some kind of a pig, something that they put in to fix the defect. But they replumbed her kidneys, and she still has kidney damage, and she's been dealing with that the rest of her life. But she's alive today, and getting ready in her late 60s and living well. So it's important, I think, to recognize that miracles do happen sometimes, and there are we don't always know everything. So I think, from my opinion, and it's one opinion, that if a patient wants to know, they should have the right. I also think they should have the right to withhold it. And I'll give one last example. I know I'm giving lots of examples, but I think
one more
they
example, because we
help the
got
story.
comments here. I want to read
Okay.
off.
All right, absolutely. So this is a story about a young man we treated at the Pain Institute who was dying of cancer. And his mother wanted his medical records. And he said, do not give my mother my medical records. I don't want her to know how sick I am. We had to honor and respect that. He was an adult.
Okay, yeah. Okay.
We had to honor and respect that. So yeah, go ahead.
Yeah. Okay. Social determinants of health should be included in medical records. I think we would agree on that. Let's see. The data is collected differently, organization to organization, and data governance differs. When sharing organizational data, we do risk conflicting information. Okay, this is interesting. How can we create a true patient journey outside of account by account?
Yeah, so what we believe at iShare Medical is that there should be a complete medical record organized around the person. So the way that records are created today are provider-centric. In other words, I have a record at the hospital. I have a record with Dr. Smith and Dr. Patel, and so on. And each record has a little piece of information. Some of it's the same, some of it conflicts. That is not the way to do it. The way to do it is a complete medical record organized around the person that is shared amongst all of your providers would have access to that data. And that's what we're doing at iShare Medical.
Wow. Okay, that's super helpful. Another comment here. Maybe they need to know so that patients and families can make the appropriate decisions for the whole family's well-being, and including care of the children. Uh, oh, yes. Yeah. I think if
Right.
people know the truth about their condition, they often would make very different decisions as well. And I have been in the position of speaking to patients, and I know they're dying based on the treatment they're receiving, but they don't know they're dying. And you know, and it's not really my place to tell them, but their doctor did not tell them the stage they're in. The doctor did not tell them the treatment they're receiving is palliative. They just assumed because their doctor gave them medicine that it was curative. Um, you know, and yeah, I just, people would make different decisions.
Right.
And I also look at it as, and this is not being morbid, we're all going to die. We're all going to die. Like that's a fact. We're all born and we all die. Those are two things we all as human beings have in common. Maybe only those two things, but we have those in common. And so, you know, even with a cancer diagnosis or a serious, you know, kidney disease, you know, yes, you're going to die. You might not die from that, but we're all going to die. So I think a lot of it's just issues with facing our own mortality. Let's see. And then one more comment, something about federal regulations say doctors decide if release of information causes harm. Okay.
Yes, they do. So,
Yeah.
kind of this is kind of a 30,000 foot crash course on HIPAA, but basically the patient has what's called the individual right of access, always has. The patient has a right to their medical records. Now, the HIPAA was created in 1996, the Healthcare Portability and Accountability Act of 1996. And what it said was establish rights when you're not the patient. So HIPAA says that a doctor who is taking care of you has a right. They're called a covered entity, but the providers that are taking care of you have a right to medical data so they can take care of you. Your insurance company who's paying the bill has the right to the medical data so that they can process the claim and pay for it. And any business associate working on behalf of the doctor or the hospital. So we, for example, work as a business associate. We help share the medical records. We don't look at medical records. We have no right to look at them, but we do transport them from one place to another so that there can be interoperability. So we function as a business associate. That's what HIPAA does. I think it's widely used for all kind of crazy things that it isn't about. It's about establishing who has the right to look at that information, and so that they can take care of you or pay the bill. And if you don't want your insurance company to know, you have the right to say, don't file this with my insurance company, in which case the insurance company does not have the right to your data.
Wow. Okay. I didn't know that. Can you say that one more time about the
Sure.
insurance?
So let's say that I'll take an example. Let's say that there's a man and a woman getting divorced. I'll take the woman's role here. Let's say that she's really struggling with the divorce and whatever. She decides that she wants to see a psychologist or psychiatrist and talk about it. And if she says to her psychiatrist or psychologist or any other doctor, this is just an example, I don't want my records filed with my insurance company. I will pay for them. You still have to pay, but don't file them with my insurance company. Then the psychologist, and it could be any kind of thing, could be a cancer doctor, could be in primary care, whatever. Do not share my records with the insurance company. I will pay for them. Then they don't share them. So when you go to the doctor, you do something that's called assignment of benefits. I, the patient, assign my benefits to you, the provider, giving you the right to bill my insurance company and get paid. In the course of that, I understand that you're going to share my medical records with the insurance company. You usually sign that. You may not read it. Oftentimes,
Right.
it's accompanied with a financial policy that says, if my insurance company doesn't pay, I understand I have to pay.
Yeah.
Right? But you may not understand what you're signing to, but you're basically giving the patient always authorizes. The patient consents to treatment. The patient consents to billing. The patient is in the driver's seat in this. And if you say, we had work comp patients who were injured at work and they didn't want the work comp carrier to know about that. And we would say, fine, we don't have to send in the records, but that means work comp's not going to pay the bill. Are you okay with
Right.
that?
Right.
Just as long as they're okay with that, and you have to pay the bill. So yeah, you have the right to deny access to your medical records.
Wow, very cool. Linda, this has been awesome. I absolutely adore you. So if you want to learn more about Linda and iShare Medical, you can look at the bottom. There's a little crawler, whatever they call it, going across the screen. Her website is isharemedical.com. Or you can call Linda at 816-249-2555, extension 101, or just shoot her an email at l.vanhorn@isharemedical.com, and she does have these amazing monthly webinars you can sign up for and learn more about what she does. Thank you so much for joining us, Linda. Thank you for the interaction and the comments, and I know more are to come. And if you like these LinkedIn Lives, please join us next week where we're going to have a new topic. We're going to be speaking with Richard Luftig from Castle Placement and talking about choosing the best fundraising vehicle for your startup, another topic that I'm very passionate about. So thank you, everybody. Have a great oh gosh, no, I can't edit it out. It's live. This sucks. Sorry.
That's right.
Thank you. Have a great rest of your day.